pediatrician who's now retired, but practiced about 20 years of my working life in private practice and about 18 to 19 years as a faculty at the University of Kentucky in the Department of Pediatrics. So I kind of had both worlds. But mainly I focused the last few years of my practice on the care of children with ADHD and comorbid conditions. And of course, depression and suicide risk is part of comorbidity for ADHD. So today we're going to review the suicide screening tools. We're going to review risk assessment. Screening and assessment are two different things. We can use screening tools in our practices, but if they're positive, then we need to proceed with a risk assessment and a prevention plan. And what I'm proposing in this protocol is there's no protocol that fits every practice. So take what works for you and leave the rest if you can find things that would work in your practice. I just want to point out that suicide is a public health problem. And now the National Institute of Mental Health is really focused on providing us with tools to help screen for suicide risk, but also to assess suicide risk, because in all ages, there are 132 deaths per day, but in the age group of 10 to 24, there are 18 deaths every day from suicide, and it is the second leading cause of death in that age group. And of all the deaths in that age group, 26% of them were deaths by suicide. So it's a significant problem, and we are poised as pediatricians to really address that issue because we see kids for well child visits, but also for complaints, somatic complaints typically. And so anyway, about 80% of pediatricians have had a patient who either attempted suicide or died by suicide. But with that number, and you look at the pie chart, 61% always screen for suicide. So there are still a number of pediatric groups or pediatricians who are not screening all the time, sometimes 37%. I think we can improve that because there are missed opportunities. Most of the young people who die by suicide had contact of some type with a medical professional. That's us or emergency room folks. 80% of youth had visited a healthcare provider. 38% had contact with the healthcare provider within 4 weeks of their completed suicide. 50% had been to an emergency room within the past year. And when I mentioned somatic complaints earlier, so I think it's important to screen in our well child visits, and I'll talk about that in a minute. But it's also really important to listen carefully because headaches and stomach aches sometimes are expressions of emotional distress and pain, and those are the kids that may be considering hurting themselves. And in terms of COVID, there's been an increase in emergency room department visits. We don't know about primary care office visits, but at least in emergency rooms, there was a 39% increase for suspected suicide attempts between February, March of this year compared to 2019, which is pre-COVID. That increase was 51% in females and 4% in males. It is so important, of course, all of us know, to prevent suicide. In the Youth Risk Behavior Survey in South Carolina high school students, we were fairly high. 39% felt sad or hopeless. About 20% had seriously considered attempting suicide in the 12 months prior to the survey. That's 1 in 5. That's 1 in 5 of your high school students that considered suicide. 15.7% made a plan, and then 11% actually attempted suicide 1 or more times in the 12 months prior. Fortunately, 2.5%, and in the US, 3.5% resulted in an injury or poisoning or overdose that had to be treated by a doctor or nurse. So kids are thinking about hurting themselves. And so that's the bottom line. They're thinking, and this may include some of the non-suicidal self-injury or cutting injuries that we see. Then there's attempt, and then finally death. And that's what we would like to, of course, prevent. And the non-suicidal self-injury, there's more and more research coming out now about those behaviors, and they tend to happen in very intense mental, physical urges for patients. I had a young lady describe to me why she cut, and it was a release for her. She had this just very intense emotional distress, and when she cut herself, it seemed to release that distress. So we do know that those people who cut themselves or hurt themselves do go on to attempt suicide, not all of them. We also know that those are the patients who have a history sometimes of physical or sexual abuse, and that the abuse was continuous for that particular patient. That's the most common issue associated with the non-suicidal self-injury. So what do we need to know? 48%, so almost half of suicide attempts occur within 10 minutes of a crisis. And if you think about the developmental stage of age 10 to 14, or even up to 19, kids are not very insightful. They have tremendous impulses and difficulty controlling their emotions. And so there's a crisis that happens, and 10 minutes later, they're attempting suicide or sometimes completing suicide. The good thing is that 9 out of 10 actually do not go on to die by suicide later. But if they choose a means that's very fatal, like a firearm, that will determine whether they live or die. And in the United States overall, firearms are the most common cause of deaths. Suffocation, and suffocation means hanging or plastic bags over the head. There are different forms of suffocation, but in our age group, it's mostly hanging. That's the second most common cause of suicide in South Carolina and the US. And then the third is poisoning, and poisoning is usually associated with some type of overdose or medications that are available to the patient. I just wanted to show that the trends from 2010 to 2019, the actual deaths in suicide, from suicide in South Carolina, are definitely increasing. And the firearm deaths are increasing, suffocation deaths are increasing, poisoning deaths have actually declined some. But the bottom line is that it is a very common problem in this age group that we see, the 10 to 24-year-old, which is the way. It's frustrating to me that almost every study you read about suicide has different age groups. There's the 5 to 12, then there's the 5 to 14, and then there's the 15 to 19. So it's difficult to sort of get an overall big picture, but I think you can feel assured that the big picture is that suicide is happening in all age groups. Of course, as teenagers get to 15 to 19, it's more common to be completed. It is important to remember your language, particularly these words right here. Instead of saying they successfully committed suicide, it's much better to say there was a suicide death or a suicide attempt. This language matters when you're talking with caregivers, families, and patients as well. And calling someone borderline or treatment resistant is not particularly professional, and we need to use the words diagnosed with, or not ready to engage, experiencing the challenge differently. I really like that one, instead of in denial, because denial to me may be very different from denial to my patient. So we know right now that the American Indian, Alaska Native, which we don't have very many of these youths in South Carolina, but they have the highest youth suicide rates right now. Black teens also have the fastest growing rate. And we know that our LGBTQ youth are much more likely to attempt suicide compared to heterosexual youth. I think that's a reflection of the societal bullying that they experience and personal bullying, all of the things that go along with the LGBTQ youth. And remember, there's no one size that fits all, but if you base your approach to suicide screening and suicide assessment on the strengths of your patients and you're culturally sensitive about your patients, that is the best prevention strategy. And so I'm going to go through this. This is just one option for as a protocol, the screening tools, the interview, assessing the patient, which involves identifying risk and protective factors, but also asking really hard questions, the suicide inquiry, and then deciding, are they low risk, moderate risk, severe risk, and that's a judgment call. And then prevention, so safety plans, lethal means, counseling, and crisis referral if needed. Then I want to talk just a minute about treating depression, if that's appropriate in your practice and for your patient. So this is what we'll look at, and we're going to talk about screening right now. So my recommendation, and I think the National Institute of Mental Health recommends all patients age 10 and up. So if it's a new patient or it's a well child visit, if it's an existing patient that you're concerned about and has not been screened within the past month or so, or if a patient had a positive suicide risk screen at the last screening, that would be important to do another screening. If you have younger kids even who have psychiatric complaints or behavioral health complaints, that's important to screen those kids as well. So when you think about tools, screening tools, depression screens we're pretty familiar with. And the PHQ-A is basically the PHQ-9 that's modified for adolescents. And I'm sorry, the lawnmower, if you can hear the lawn mowing noise, they won't be long. But these are for depression. And if you only use depression screens, you will miss some suicidal patients. For example, if you just use question 9 from the PHQ-9, more than half of suicidal patients are missed. If you use the PHQ-A or PHQ-9, the whole screen, about 32% will be missed. And that's information from the National Institute of Mental Health. So there are suicide-specific screens, the ASQ, which is what the National Institute of Mental Health recommends. And then there are other, the Columbia Suicide Severity Rating Scale, SAFE-T, there are other suicide-specific screens. But the bottom line is that if you add the ASQ questions to the PHQ-A, that's the best screening tool, and you don't have to do 2 screens. If you can just put them together and have the ASQ questions maybe at the end of the PHQ-A, then that's the best screen for depression and suicide. So the ASQ questions say, past few weeks, have you wished or you were dead? In the past few weeks, have you felt like your family would be better off if you were dead? Have you been having thoughts about killing yourself the past week? So it starts out few weeks, past week, and then right now, number 5, are you having thoughts of killing yourself right now? So if the 1 through 4 questions are no, then you really don't need to proceed. That's a negative screen. But if any of the 1 through 4 are positive, then you do need to go ahead and ask question 5. So the PHQ-9 and A, the screen for depression, and we all probably know the scale and how you score. And 10 to 14 total is moderate, 15 to 19 moderately severe, and 20 to 27 severe depression. So if you have a positive PHQ-9, PHQ-A for depression, and then you have a positive ASQ, then you know that you really need to do a suicide assessment. This is the same thing I just said. If they answer no, it's a negative screen to the first core questions. But if there's a yes, then you do need to ask 5. And then if 5 is positive, then it's important to then go ahead and do a suicide assessment. Now, if you only use a depression screen and you get a positive PHQ-9 or PHQ-A for serious depression, there are other suicide screens you can consider using, but it's a second screener that you do separate from the PHQ-9 and PHQ-A. The other option is just to ask the patient directly about their suicidal thoughts and let them know that other people have similar thoughts and feelings. I think that's one of the key issues with screening for suicide, is that teens need to understand that other teens have similar thoughts. This is just the Columbia Suicide Rating Scale and the Suicide Behavior Questionnaire. And there are practices that prefer to use one or the other after they get a positive PHQ-9 or PHQ-A. However you do it, the bottom line is, if your screen is positive, you definitely need to assess the patient and interview the patient. Going back to our adolescent teaching, the HEADS is still very useful to ask the patient how they're doing at home, education, their eating, their activities, drugs, and then sexuality, safety, suicide, and depression all come in there. And I think it's important to say to the patient, if the screen is positive, I want to follow up on your responses to the suicide risk screening questions. Thank you. Thank you for letting us know you're having these thoughts, because these are hard things to talk about. And I need to ask you a few more questions. And you can do, I think it's important to interview the patient alone and interview the patient and parent together, and discuss social stressors that are going on for the patient and the family. Remember, strength-based and culturally sensitive interviewing is your best prevention strategy. And these sample interview questions just came straight out of Bright Futures. In terms of, do you ever harm yourself, such as cutting, hitting, pinching? Do you carry a firearm? Do you ever feel so upset that you wish you were not alive, or that you want to die? And these are questions that you can ask directly to the patient. But then if you feel like you need to really assess the patient because the screening is positive, you want to look at the risk factors. And these are some of the risk factors that make it more likely your patient will attempt suicide. If they've had previous suicide attempts, if they have mental health diagnoses such as depression or bipolar disorder, they have alcohol or drug use, if they've had an acute stressor like a death in the family, if they're being bullied, they have a boyfriend or girlfriend breakup type relationship problem. I had a young student who was, he was a junior in high school. He was in his first relationship with a girl, and they broke up, and he became acutely suicidal because it was the first time he'd had a broken heart, and he didn't understand that broken hearts do heal, and there is light at the other side of the tunnel, and that's our job to help them understand that. So also, if there's a history of trauma for the patient, that's also plays into increased risk. Family history of suicide, and if there's chronic disability or illness for the patient. In addition, how the patient feels internally, hopelessness, impulsiveness, isolation, aggressiveness, and I underline that because aggressiveness is one of the key factors that does tend to make suicide attempt and suicide completion higher. So if you have a patient who is exhibiting aggressiveness or feeling very aggressive, that's significant. Giving things away if they're hurting themselves. And the other, I think, factor is that if they're unwilling, if they're just flat out, nope, I don't need help, that is a risk factor, increases the risk for the patient. And then we want to look at the other side, the protective factors. So is there connectedness? Are the parents able to provide monitoring and support? Does the patient have coping ability, frustration tolerance? And these are things sometimes that really don't develop in a concrete mind until the age of 15, 16, 17, 18, and sometimes not even then. In fact, sometimes it's not even there at age 25. So the bottom line is that you want to assess what your patient's ability is to cope with whatever the stressor is that's causing them to consider hurting themselves. There's also cultural, religious, and personal beliefs that discourage suicide. Sometimes those beliefs can be helpful in protecting the patient. So then the hard part is asking the very direct question. Ideation just means the patient has ideas about committing suicide, about killing themselves. And you want to know how frequent those ideas are and how intense they are. And a good way I feel like to ask is, how many hours out of the day do you think suicide is on your mind? Or how many minutes in the last hour was suicide on your mind? And so then you get a sense of what's going on in their mind. You want to know what they're planning, how lethal the method is, and have they been practicing? We call those rehearsals. Have they practiced hurting themselves or practiced a suicide attempt? Have they had past attempts? And then how intent are they on carrying out their plan? And is their plan lethal? And so these are some of the questions that are recommended in the suicide inquiry. You want to start out talking about the past few months. Did you think about suicide? And if so, what methods did you think about? What kept you alive? Then you talk about the past couple of days. How much has it been on your mind? And what methods have you thought about? And then have you thought about how you'd kill yourself? When or where? Are there other methods you're thinking about? They might mention one method. For example, they might mention hanging, but then there's actually a gun that's not secure, and their ability to get to it is easy. Is there a scenario where you think you would attempt suicide, and have you ever attempted in the past? So 3 things I feel like I added this slide because I feel like it's important that we not panic. In other words, the patient wants us to be their source of hope and strength. So we need to be present. We need to listen very carefully, try to reflect. I hear what you're saying, that you're feeling like, whatever, and give them hope, because you can say, you have been through a lot and I can see that you're strong. I can see that strength. And so once you have asked those very difficult questions and you have a sense of where they are, that's when you say, well, they might be low risk, moderate risk, or severe risk. If they're low risk, usually there's no intent that you detected, no previous suicidal behavior. I'm sorry. And then moderate risk, they have the ideas, but they're not intent. And there's not been any suicidal behavior in the past 3 months. But severe risk, we all have seen these patients. And I again included aggression associated with the unmodifiable risk factors, some precipitating events. They don't have really very good protective factors, and they're either had a lethal suicide attempt or they're considering a lethal suicide attempt. And those patients need, in the severe risk category, a crisis referral. These are the kids that you end up sending to either your mental health person who can see them immediately or an emergency room setting. But if all patients we see have been screened and counseled, and I think it's important, and the AAP does recommend that we talk about lethal means safety. So, and that's the firearms, and I'll talk about that in just a minute. If the patient, though, is low or moderate risk, I do feel like it's important to discuss a safety plan and make a mental health referral. You might be catching them at their vulnerable point and they haven't progressed yet to severe risk. But at that vulnerable point, if you can connect them with mental health providers, then they have a better chance of not progressing to the severe risk. So what is a safety plan? This is a sample of the Brown safety plan, which I think is really very good. And some electronic medical records are putting these in so that you can have them and not have to do it on paper. But basically it's asked, and this should be patient directed. So the patient needs to tell you, what are their warning signs? What are their internal coping strategies? Who are the people or social places that provide distraction? Does the library provide distraction for you? And who are the people you can ask for help? Not just their name, but their phone number. And then who are the professionals that you can contact or the patient can contact during a crisis? And I think this is really important for the patient to have. And some practices will fill this out and print it, and the patient carries it home. And step 6, don't forget step 6, making the environment safe. So if there are firearms accessible, lock them up. If there are medications accessible, lock them up. So I think to patients, we can say, you know, many people struggle and have a crisis and experience those strong suicidal feelings. And I want to help you make it safely through these feelings and get the help you need. But to the parent or caregiver, I think it's important to say that if a child or teenager is going to attempt suicide, it's usually at home. It's often a quick decision. Remember, half of those are within 10 minutes of a crisis. And if you can put time and distance between your child or teenager and a method that could do serious harm, that's a very effective step for the caregiver to do. Pills are the most frequent method of attempt, and guns are the most lethal. And so let's start talking about those. So making the environment safe. So lethal means firearms, removing them if possible, or storing them safely. You need the ammo separate from the gun, and hopefully you can have a lock on the critical component of the gun. Medications, and I tell parents this, it's important to lock in some type of a toolbox or and a large enough toolbox that it can't be broken into easily. And first of all, go through your medicine cabinet and get rid of all the medicine that's expired, unneeded, no longer being used. And then as providers, we need to prescribe limited quantities to these families. So medication, and if you're unsure what a safe quantity is for a particular medication, call the Poison Control Center. They can tell you. Then we look at belts and ropes. We want families to search their homes and remove things or lock them up that could be used for harm. And then sharp objects as well. I had a patient who was collecting Japanese samurai knives, I think they're called. Anyway, I hadn't ever seen them, but he was describing it in great detail and where he would use it, right across the throat. And so that's important for that family to be sure those are secure and not available to him. So in terms of medication, the overdose suicides most commonly occur with pain medications like oxycodone, methadone, morphine. But there are others, benzos, antipsychotics. It's whatever's in the medicine cabinet usually. Even over-the-counter things like Benadryl or Tylenol can kill your patients. So it's important to review with the family, not just their prescription medication, but their over-the-counter medication. And they can put the over-the-counter stuff in the same lockbox. And I mentioned this, using lower toxicity medications and limit the quantities. So for example, SSRIs and SNRIs tend to have less toxicity than a tricyclic antidepressant. The difference between a toxic level of tricyclic and a therapeutic level of a tricyclic is pretty close, whereas that's not true for not so much true for SSRIs or SNRIs. If you're worried, it's okay to do weekly refills. You can connect with the patient's pharmacy and discuss how to do weekly refills as opposed to monthly or even 90-day refills. So if you have a patient that you have assessed and that patient is in immediate crisis, I think it's so important to do the referral and have them be in sight of you or your office personnel in a place that's safe. So if that's your office, be sure you've removed sharp objects, things that they could use to hurt themselves. So once you have screened and the positive was screened and you made a safety plan and you did the lethal means prevention counseling and you made a mental health referral, and if it was severe, you did the crisis referral, it's important, I think, to think about treating the depression, which is usually associated with suicide risk. So what do we know about treating depression? I think of it as a three-legged stool. It takes medication, it takes therapy, meaning counseling, and it takes exercise. Exercise is a very good antidepressant. And so when I talk to families and patients about treating depression, I say, you got to have three legs to the stool or it's going to fall over. What we know about meds and therapy is that if you start them together, patients have a much better response rate. If you combine, for example, this study looked at Prozac and cognitive behavioral therapy, 73% had a response rate. Whereas if you just did therapy alone, 48% had a response rate in 3 months. If you just did Prozac alone, only 62%. So start them together. I know we tend to be hesitant as pediatricians to do this, but the evidence is out there that it works much better if you start them together. And your options keep getting increased. But basically, it's the serotonin reuptake inhibitors, the norepinephrine reuptake inhibitors, and tricyclics are still out there, but I do recommend avoiding those if possible. Every SSRI, SNRI comes with a box warning, and I think it's important to say to the family that there is a warning on the medication that you will receive. And if your child begins to have increasing thoughts of hurting themselves, stop the medicine and call me. I've only had that happen a couple of times in the years of practice, but it does happen on occasion. Deciding which medication requires really thinking about many factors, side effects. What's the family history? Has anybody in the family been successful with an SSRI or an SNRI? What's the efficacy? How long is it going to take for the medicine to work? That's another key factor. Prozac is about 4 to 6 weeks, and they need to understand they're not going to feel better tomorrow with the first pill of Prozac. Cost, those things all impact your decision. So what we know about that box warning is that 6 times more teens benefit from the use of SSRIs and SNRIs than are harmed. So unfortunately, we do have to explain that. We have to explain that they understand the instruction, how to take it. We need to explain that it needs to be kept in a very safe place, locked away, and safety trumps privacy. So for example, for teens, you know, we do often talk about adolescent confidentiality, but my caveat is to any teen, if I am concerned about your safety, you're going to hurt yourself or someone else is going to hurt you, I will involve your parent / caregiver, foster parent, whomever. Otherwise, everything we talk about is kept confidential. And so it is really important to say, if the patient starts to have more frequent thoughts or just increased anxiety, increased aggressiveness, unrealistic plans, these are all things that tell you they're not tolerating the SSRI or the SNRI very well, and have them stop and call you. Now, what we know about follow-up is that it's important, of course, if you're sending the patient to the emergency room, to give them important information. But even if you're sending them to the emergency room, make a follow-up appointment with yourself. Because if you have follow-up with the primary care provider of a patient who has depression, there's a significant reduction of depression symptoms if there's frequent follow-up, 2 weeks, a month, 6 weeks, 2 months, however often you can work your schedule to see the patient back, you will have better response from depression if you schedule the follow-up with you, the person they've connected with. It's also important to collaborate with their mental health providers. And if you can do that, that improves the village approach to taking care of your patients. And there are many resources that we should send our patients home with. There are certain practices in South Carolina who, for example, use the My3, and they have the patient doing it on their iPhone or cell phone in the office before they leave the office, so that the patient has access to help once they're not in your office. And I think it's also important to have all the crisis lines available for your patient as well. Changes you might want to make. Know what your local resources are. Implement suicide screening. There will be a blueprint coming out in January 2022 from the AAP, AFSP, which is the Foundation for Suicide Prevention, the NIMH, as youth suicide prevention. And I really feel like in that particular blueprint, there will be a PDF of the PHQA and the ASQ questions on one sheet of paper, which will be really helpful. There are training webinars if you're not comfortable with all of the suicide screening or the suicide assessment. There are training webinars available through NIMH or SPRC, the Suicide Prevention Resource Center. They really are excellent training webinars. I did those webinars and they're excellent. So the bottom line is, this is just a protocol that I propose, but you choose what works best for your practice, and encourage, provide strength and hope to your patients. Okay, I think Dr. Siriani might have a case to present.
Thank you, Dr. Woods. That was amazing. I'm a healthcare provider I'm a doctor of nursing practice from the rural area of Winsboro, South Carolina, and I'm also the assistant medical director for Medicaid. I'm gonna go ahead and